for the day. And our team, just a reminder who our team is, Sherry, Marina, Michelle, and I are with the Washington chapter of the American Academy of Pediatrics. And Annika, Mercine, and Doug are our physicians from Seattle Children's Hospital. And for MOC, Siri Yip is a point of contact at Seattle Children's Hospital if you ever have any issues with MOC. And then we're so grateful for our funders, Public Health Seattle King County and the Washington State Department of Health, who make this initiative possible. Christy Anstapp is our main point of contact at Public Health Seattle King County. And Crystal Averett with the Washington State Department of Health is on the call with us today. And Crystal is a great resource for you on all things IIS, the immunization registry for kids. And there's all kinds of functionality there that you should know about, and Crystal can help you learn about. You'll have the opportunity to meet with her about your clinic's own needs so that you can at least know what's possible through the IIS. So thanks for being here this morning, Crystal. And then I want to acknowledge we have extra support from 2 health plans. Melina helps support the race and ethnicity and language work that our team does to help you look at your equity and care. And then WellPoint, we'll talk later in the presentation about some support that WellPoint is providing for you to outreach to patients and stand up vaccine clinics. So really appreciate that extra help. Next slide. So just a review of who's here. Such a wonderful diversity of clinics and from both geography and clinic type. And we're also really impressed with how many people at your sites are participating. So this is really cool and I think is going to lead to a lot of success. Children First Pediatrics, Harbor View Family Medicine, Mason Clinic, Neighbor Care Rainier Beach, and Newport Health Center. And we're going to just jump right in this morning so that we have plenty of time for questions and discussion too. So we're not going to do full-fledged introductions today. But we'll do them at our calls so that you guys get to know each other, our future calls. And then great team from Odessa Brown and Pediatric Specialty Practices, Swedish Edmonds Birth and Family Clinic, and Swedish Standpoint. So I think this is probably the most family medicine we've ever had in a cohort, which is really great to see because I know when every single patient is a child, it's a little easier to do standard practice. And so really appreciate family medicine being here because, you know, only a part of your panel is pediatrics. And so getting that routine and standard practice is a little bit harder. So it's really great that you're here because we hope we can help you. Next slide. So just a reminder that our overall aim is to increase child and adolescent vaccination rates at your clinics. And then by September, we hope that all of you will have reduced missed opportunities by 20%, so that when kids come to your door, they're more likely for you to know their vaccination status and catch them up if they need to be. Reminder of the definition of missed opportunity. It's a failure to vaccinate a patient who's eligible for a vaccine at an office visit. And I think with that, I turn it over to Annika.
Thanks, Sarah. So we're just going to jump right in and start first with a focus on why we need to optimize childhood and adolescent vaccination in Washington State. So just initially to review our childhood vaccination guidelines. So as you all know, the U.S. Advisory Committee on Immunization Practices recommends for children who are 4 to 6 years of age that they receive the following vaccine doses. So that includes 5 doses of DTaP, 4 doses of inactivated poliovirus vaccine, 2 doses of MMR, and 2 doses of varicella. There are, of course, catch-up schedules, so some children who've received doses late may be needing fewer doses, but in general, this is what most children should recommend or should receive. Here in Washington State, these are our school entry requirements. So in 2022, the Washington State Department of Health updated their guidelines to state that children who are 4 years of age or older as of September 1st and who are entering preschool, childcare, transitional kindergarten, or kindergarten must have those same doses of vaccines. So 5 doses of DTaP, 4 doses of inactivated poliovirus, 2 MMR, and 2 varicella. And then in addition to that, they need to have completed their 3-dose hepatitis B series. And that's important. The Washington State rules are important because although we have that 4 to 6 year window in which we can give the vaccines according to the ACIP schedule, it's important that we are giving vaccines in the clinic setting as early as possible. So at the earliest opportunity in order to best protect children to diseases that are present within the community. But we also know, and particularly during the pandemic, that some children aren't accessing care always at their 5-year visit and 6-year visit. So we really want to, again, capture those opportunities when they arise. And then just a review of the adolescent vaccination guidelines. So the Advisory Committee on Immunization Practices recommends the following doses for children ages 11 and 12. So that includes 1 dose of Tdap, 1 dose of meningococcal vaccine, and then completion of the HPV vaccine series. So for HPV, for those patients who start the series before their 15th birthday, they need 2 doses. If they start the series on or after their 15th birthday, or if they have certain underlying immunocompromising conditions, they would need 3 doses. The ACIP states that it is also acceptable for patients to receive the vaccine, HPV vaccine at 9 to 10 years of age. The American Academy of Pediatrics actually has come forth with a recommendation that we give it between 9 and 12 years of age. So a stronger recommendation for starting early. And here in Washington State, we have also endorsed that earlier vaccination schedule with HPV and giving at 9 years of age. So you'll note, for those of you whose electronic health record interfaces with the IIS, or the Immunization Information System, or child profile, you'll note that the forecasting is set up to begin thinking about the HPV vaccine at 9. And Sherry Zorn, Dr. Zorn is with us today, and she's going to talk a little bit more about that a little bit later in the talk. Here in Washington State, in terms of our school entry requirements, children need a dose of DTaP at age 10 or older as they enter into 7th grade. But as you know, meningococcal and HPV vaccine are not required here in Washington State for school entry. So now I'd like to review some of the data that we have for Washington State, and this is specifically looking at Washington State data as well as data from our 4 counties represented in this cohort, so King County, Mason County, Pend Oreille County, and Snohomish. And you can see here, this is looking at data from IIS from Washington State from 2018 to 2021. So these are the latest data available, and looking at the proportion of 4 to 6-year-olds who are up to date on all recommended vaccines. So that includes a broader array of vaccines than what I just mentioned. So doses that are also due at earlier age points. And you can see here that during this time period, vaccination coverage was relatively stable across all sites, hovering around 40%, 40 to 50% at most sites, lower at 20% in Pend Oreille. Although I'll note there was a smaller sample there in Pend Oreille. So obviously, though, for all sites, an opportunity for improvement. Here are our data for our cohort 6 practices, with the exception of Newport, again, who had a very small sample size, so we didn't report the data here. And this metric is a little bit different than what we just saw. So this is looking at the proportion of 7-year-olds who have received 2 doses of MMR, 2 doses of varicella, 5 doses of DTaP, and were up to date for IPV by their 7th birthday. So as you recall, these doses are recommended between 4 and 6 years of age. So we use that 7-year cutoff as the time point at which these children would actually be delayed or overdue for these vaccines. So all children should have received these vaccines by this time point. And you can see across all of the clinics that the proportion is hovering around 80%, with some lower and some higher, depending on the clinic, depending on the year of data collection. And then if we switch to our adolescent vaccination data, this is looking at the HEDIS Combo 2 measure and looking at the proportion of 13-year-olds who've received at least one dose of Tdap, one dose of meningococcal vaccine, and were up to date on HPV vaccine by their 13th birthday. And if you remember, with ACIP, they recommend these doses at 11 and 12, so by 13 they are overdue or delayed for these vaccines. So you can see here again, looking at Washington State data, and then our 4 counties represented here. And Washington State data is hiding behind Snohomish, mapped very similarly, but you can see that the proportion of adolescents who've received all of these recommended vaccines is quite low. And we were missing a data point in Pend Oreille in 2020. I will say that this is almost entirely driven by the HPV component of those requirements and completion of the HPV vaccine series. When we look at that same HEDIS Combo 2 measure in our Cohort 6 practices, you can see that most of the clinics are hovering around those same proportions as we just saw, looking at the county level and state level data. So around 30 to 40%, some higher, some lower, depending on the year and the clinic. And you'll note that some clinics saw declines during the pandemic and others saw some increases. So quite a bit of variability, but across the board, obviously a lot of room for improvement. And as we think towards how we can improve vaccination uptake and coverage in our clinics, the first step is really to identify the barriers and the challenges that we face in vaccinating our patients. So we just wanted to take a few moments to review some of the common barriers that we see with respect to vaccinating children and adolescents. And I think the first point is just acknowledging that it is really hard to get patients vaccinated on time. And there are a variety of reasons for that. At the family level, they may be unaware that a vaccine is due and that their child is behind or due for a vaccine. Some families may be hesitant about vaccinating their child for a variety of reasons, and certainly we are hearing that very commonly, during the pandemic and in the wake of the pandemic. And thus, some families need multiple conversations with their healthcare teams about vaccines. In addition, we know families may miss preventive care visits, so they may face limited access to care, and certainly that was true for many families during the pandemic. They may face other challenges, for example, a lack of insurance or transportation challenges, difficulties taking off work or finding childcare. And then many families face competing demands or stressors, and all of those can contribute to them not getting into clinic to see all of you and get caught up on vaccines. But we also know that, even when we have patients in our clinic, we miss opportunities. And so there are a variety of reasons for that. We may not know a child's vaccine eligibility status, so we might not identify those children who are in need or due for a vaccine. Concomitant vaccination may not be offered. So when we have a patient coming in for their school-required Tdap vaccine, are we offering them HPV and meningococcal vaccine? Or when they're coming in for their fall flu vaccine, are we checking their records to make sure there's not anything else due? We also know that vaccines are not given during all visit types. So in general, and we, having looked at a lot of the cohort data over the last few years, we know that we do relatively well in our preventive care visits or in our well child visits. But when we expand to looking at our acute care visits or our mental health visits or other reasons patients and families are coming in, we're missing many opportunities to give vaccines. So something for us to think about in this cohort and whether that might be a strategy you might want to employ. We also know, of course, that we can have periods where our supply is disrupted, and so we may have inadequate supply. A fridge may go down, and that can cause storage issues. So these challenges are also contributing to missed opportunities. And then importantly, we know that the healthcare provider recommendation is one of the strongest predictors of vaccine acceptance and vaccination of children. And so the converse of offering a weak recommendation or not giving a recommendation during a visit can be a barrier to vaccination for families. And along with it, the personal beliefs of healthcare staff around vaccination are important. So now we want to switch gears and think about ways in which we can address some of these potential barriers and challenges that we face with respect to getting children and adolescents vaccinated in our practices. So here's just sort of a broad overview of some of the evidence-based strategies that you could use to improve uptake in your patient population. So at the patient and family level, we have reminder recall initiatives and educational materials and resources for families. At the staff and provider level, it's important to focus on evidence-based communication strategies, employ huddles between members of your care team on a daily basis to identify children who need vaccines at the visits, to use vaccine prompts or standing orders to offer and administer vaccines. And then at the practice level, thinking about ways to standardize our vaccination practices in terms of the vaccination schedule that we use in the clinic, or the types of visits and where you're offering it in your standard workflows, offering expanded hours to increase access and accessibility and availability of the vaccine to patients and families, and then measuring and sharing our practice rates. So we're going to take a little bit of time to walk through each of these in a little bit more detail. And so here is a slide that should look familiar to you. Mercine introduced our suite of interventions at our meeting last week. If you recall, reminder recall is in green because this is a strategy that we are hoping all of you employ in your clinics during the cohort, if you're not already. And then we are hoping that you add to that at least one of these other interventions. And those could be at the parent and family, patient and family level, at the staff and provider level, or at the practice level. And we talked a little bit about these levels of reliability, again, aiming to sort of take the human factor out of some of these and standardize them in your practices so that they are sustainable moving forward.
Monica, I'll just add, if you don't mind going back one slide, Marina.
Please, yeah.
We mentioned, and we'll talk a little bit more at the end of the presentation about some additional support we have for you for that reminder recall work, the outreach work to patients. We have some additional support for that. And also for increasing your access for vaccines, so standing up vaccine clinics. And so you see that is the standing up vaccine clinics and increasing access is a little bit lower level of reliability, but we're hoping that you can bring those two things together. The high reliability of reaching out to those patients to let them know they need to come in, and then creating more access if you need to, with some financial support to stand up clinics. So those two things paired together can be really powerful. Chris, I see your hand up.
Yeah, thanks. Could you quickly review what that reliability percentage actually means? Like 99% reliable in terms of achieving what? I'm sure you've explained it earlier.
Great.
I'm sorry.
No, great. I don't think you missed it. That's such a great question. I'm going to let Monica take it.
Yeah, I think it's just sort of a delineation of which of these strategies we feel is most reliable in terms of implementing change and in a standardized, consistent way and sustainable moving forward. And so I think that there's some, subjectivity a little bit to some of these, but just sort of a range of what we're thinking in terms of reliability. So making sure that with reminder recall, you have standardized practices in place for sending out your messages. And we're going to talk more about that. Standing orders, another one where when you have it implemented within your EHR and you have your policies in place to allow your nurses or your MAs to give the vaccine, you are implementing a workflow or a process change that hopefully can continue well beyond this project and is not reliant on one individual person to make that change.
Okay, so I guess I was wondering what's the numerator, what's the denominator for these reliability things, but
Great
maybe.
question. I don't know, is Doug on the call?
I see him out there.
Yeah,
I'm here.
Doug created this original slide, so I'm going to defer to him on your specific question there.
Chris, I would just think about it as, out of 100 times, how many times did this actually get done the right way? And 99% then would be 99 and 100 times this intervention was done because it's fairly automated. It's not dependent on humans and sort of our awareness of it, and therefore is likely to happen. So
Okay.
that's really the intention here.
So it's in terms of getting done, not
Yes.
necessarily effectiveness in resulting in a vaccination.
Correct, but yes, exactly. And I would say on that latter point, we chose these suite of interventions because in general they're evidence-based to improve vaccination. But yes, this reliability is more relying or reference to the likelihood of them consistently being done.
Okay, got it. Thank you.
Thanks, Doug. Okay, so switching gears and sort of diving in further to some of these interventions. So first focusing on vaccine reminder recall. And so what is vaccine reminder recall? So this is a strategy that is used to identify patients who are due or overdue for vaccines, and then send messages in a variety of forms to patients and families in order to increase timely, up-to-date vaccination. And so how does reminder recall work? And it's really meant to address common reasons for missing doses. So this could include families who've forgotten or missed an appointment for a well child visit. They may also be unaware of the vaccination schedule and that their child is due for a vaccine. So this message is really meant to serve as a cue to action for patients and families to get them into clinic to get that vaccine. And so that piece, that cue to action, is really important when we think about implementing vaccine reminder recall in our practices, because we want to make sure that when you're sending that message, they have the potential to act on it right in that moment. So if you're sending a text message reminder, you want to send it at a time when your clinic is actually open, when they can call to make an appointment, as an example. In terms of reminder recall effectiveness, reminder recall has been demonstrated to be effective in a variety of different patient populations and settings. So thinking about different age ranges of patients, a healthy general pediatric population, as well as patients with underlying chronic medical conditions in both primary care and subspecialty care settings, in urban and rural communities. And then they've also demonstrated effectiveness across different types of reminder recalls. So thinking about automated phone calls or sending out letters, text messaging across different messaging content. So thinking about your conventional or your plain messages who are just telling you the basics of what you need to know, as opposed to adding a sort of a layer of educational content to that. Why is it important to vaccinate and come in for that appointment? And then they've been used to target different vaccine groups. So you can see here, this is from a Cochrane review from 2018. Looking at childhood vaccines, adolescent vaccinations, and flu vaccination, and you can see that in all of these cases, there was an improvement in vaccine receipt in those studies. So here are 5 steps that you could use in your clinic as you're initiating reminder recall. And I'm going to walk through these briefly today, but you'll have more opportunity during your coach calls coming up to sort of dive into the details and so that we can provide support in the work that you're doing around reminder recall. So the first step is to identify patients to target with reminder recall. So this could be done in a couple of different ways. You could identify patients who are due for a well child visit and pick an age group in particular where you know they're going to be in need of vaccine. So for example, you could send letters or use automated phone calls to reach out to families whose child are due for their 4-year checkup and thus would be due for their 4-year vaccines. You could reach out to a group of 8-year-olds who are due for their 9-year checkup, and you could talk about starting HPV at 9. So that's one possibility. Another possibility is to actually identify those patients who are due or overdue for vaccines. And you can do this through many different electronic health records and using and leveraging the tools that exist within your system. And you can also use the Washington State Immunization Information System, or WAIS, or Child Profile, and you can use that as a tool to identify patients in your practice who are due or overdue for vaccines. And so in your upcoming meetings with Crystal, your one-on-one meetings with Crystal Averett from the Department of Health, you can learn more about that functionality. And Crystal's going to also talk in a few minutes more about that.
And Annika, I'll just to tag on to Chris's question about reliability and what you and Doug had to offer. I've worked with clinics over time in this initiative and in the line of my job that how they identify the patients to outreach to is cyclical. And there's an intentionality around who they reach out to when. And I would venture to guess that it is increasing the reliability of what they're doing because there's an annual cycle to what they do. Then this doesn't have to do with our vaccines, but every September, it's all the asthma patients who you're really pulling in for flu vaccine. Every spring or early summer, really getting those incoming kindergartners in so that they're ready for school. And so that's a way we know how busy everyone is. Right? We really understand that and how staffing shortages and unexpected outages can really affect your ability to do this work. But if there's some real intentionality about who you want to reach this month, identifying who those kids are and focusing on what you can do and who you really want to bring in, then this could be more sustainable and reliable. So I just encourage you to have those conversations with your coach and your whole clinic team about who do you really want to focus on and at what time points. Because then it'll feel like a win to the team that you're really getting those kids in instead of being overwhelmed by the volume of kids you have. So Thank you for letting me jump in.
Yeah, no, thanks, Sarah. Anytime. And just to sort of add to that, I think that that's a really key piece is not to bite off more than you can chew, so to speak. So you always, with reminder recall, want to think about those downstream consequences of your messaging. And you don't want everybody in your practice to be coming in or calling the clinic the day after they get this message. So, and we know that there are staffing limitations. So, this can be a slow sort of steady work towards bringing in or implementing your reminder recall. So starting with smaller groups of patients that you're targeting is a wonderful strategy and more sustainable and more feasible for you in your practice. So that's the first step, is identifying those patients who, to target with your reminder recall. The second is selecting your reminder recall type to use in your practice. So again, there are a variety of different modalities that you could use. You could use automated phone call messages or automated text messages. You could use in-person phone calls. You could send out postcards or letters. This could be done by your staff. There are also ways to leverage the IIS and the tools and the functionality that exist within our Washington State Registry. And again, Crystal's going to talk more about that in a cool template that was just recently developed for letters to go out for reminder recall. And then after you've done those two things, you're going to develop your reminder recall message content. So that should include the who, what, where, when, and potentially also why. So depending on how much space you have, but thinking about who you're bringing in, which child are you focused on, what are they due for, what does the family need to do, what is the ask? You're asking them to call the clinic to schedule an appointment. Is there a time frame for that appointment? Do they have an upcoming, birthday, or they need to come in for their fall flu shot? And then how they're going to go about doing that. And then the why is, why is it important for them to get this vaccine? And then you're going to go ahead and send those messages and track process and outcome measures. And we're going to talk more about the last point again during those coach calls. So here I'm going to turn it over to Crystal to talk a little bit more about the cool tools that we can all be leveraging through our state registry.
Hi, good morning, everyone. So I'm Crystal Averitt with the Washington Department of Health. I do a lot of IS training as part of the Immunization Quality Improvement for Providers Coordinator. And some of the functionality that we have, there's 3 specific quality improvement tools within the IS. One thing with the IS reminder recall, if you do not have this functionality within your EHR, it is available free, no charge. This is something that you can use. There's different ways that you can use the IS to pull data. It could be letters, it could be data for an auto dialer to upload into a different system. And sometimes just pulling a patient list and looking at calling those patients back individuality. So one of the things that we'll kind of discuss with training is in the reminder recall is kind of looking at your patient population. We know a lot of children move out of state. They may be under your population. We kind of look at how to quickly and effectively get those patients inactive. And again, looking at some of the data that is coming over if you have an EHR to the IS. You can go to the next slide. And again, here are the 3 tools in this PowerPoint. All these resources are linked to our IS training portal. And we actually have created some more since then. Go ahead, next slide. And again, even through your projects, after we do training, you want to ask some questions. I am available to you guys. I'm kind of like your IS outreach. I have developed a new tool, kind of like what Annika was talking about. As we know, like I do the Immunize Washington Award, and it's sometimes not all about the 24 to 35 months or the 13-year-olds. We do have a new award this year for the 9-year-olds, but the IQIP Immunize Washington guide is really good to give you different populations, which include kids who are going into school age, kindergarten, what time to run those. Start looking at that in January, because I worked in family practice. I know that last week before school starts, they're like, I need my vaccinations for my kids, and there's no appointments available. So I, got like a really good little guide that gives you different age groups to look at, even like college kids who are seniors. We want to get those kids in before they age out of the VFC program, so that they are up to date, or either college ready, or just make sure that as they go into their early adulthood, that they have all the vaccinations that are available through the child vaccine program. So I believe that's the last slide. Oh, the reminder recall letter. So I am very, very excited about this. So last year, with working with that cohort, this was kind of a collaboration between Washington AEP, the Department of Health, and this was one thing that was identified is not being able to send out messages to parents whose English is their second language, we developed this tool. It's a one sheet. You can modify it to add your logo. Also within the IS is a way you can print labels. You can just really simple print a label, put it on the sheet, put it on the envelope, you're done. So yeah, and these are the languages that are available. So my thing with reminder recall is don't keep on doing the same thing if you're not getting that patient in. You may have, may need to say, hey, I'm just going to send this letter out because I know this patient is not responding to whether it's a my chart or, having a hard time. This just gives you a different option to try. And, reminder recall is one of those things, not one size fits all. We've got different generations. Some people like, depend on, text messages. Some people like letters so that they can like see and hold and put that up. Again, I'm through our training, I will work with you and we'll run coverage rate reports so you can see where you are at and amount for like not just Immunize Washington, but just in general. And I think, is there one more slide?
I think that's it. We're back here.
And again, I know I'm working with 2 of you all today, and I know I've worked with several clinics this week. So again, thank you guys for participating. And if you were not able to get on the schedule, please feel free to reach out to Marina. We can kind of fit you in next week if available, or week after, or a couple weeks from now. You're like, yeah, maybe we need to look at doing using the IS. It's available to you guys.
Thank you, Crystal. Thank you. And I really, we've gotten a lot of wonderful feedback over the years in past cohort participants in their work with Crystal. So I highly encourage all of you to meet with Crystal if you haven't already. And again, even if it's in a few weeks from now, that's wonderful. So thanks again, Crystal, for being here. Okay, so now we'd like to switch gears and focus a little bit on these other interventions and give you a flavor sort of each of those as you're sort of heading into your coach calls and thinking about your other second interventions or more than one intervention that you'd also like to implement in your practice. So first, thinking about those patient and family level strategies. So starting with scheduling the next vaccine visit before a patient or family leaves the clinic. So this, for example, could be used if a family comes in and they're going to be due for a vaccine before their next well child visit. An example might be they come in for their well child visit during the summer months and they need to be coming back in the fall for their flu vaccine, or perhaps they are on the catch-up schedule and so they need to be coming back in for doses before their next visit, well child visit. Another example is if they have are situations when a vaccine is deferred at that particular visit. For example, if the child has a very high fever and you've decided to wait on giving the vaccine, going ahead and scheduling that visit at that time for them to come back is helpful in ensuring that they do come back for that needed vaccine. In addition, you can review evidence-based vaccine information and resources with the patient or family. So that might include sort of reviewing those materials and resources during that visit, and sort of in line with what Crystal was just saying about that different families respond to different modalities with respect to text message reminders. It's also important to know that people respond differently in terms of their learning and their preferred communication approaches. So some people and the way that they learn. So some people are visual learners, so having sort of written materials is helpful. Some prefer verbal education, and so combining those two is helpful or may be helpful for certain families. Along those lines, actually giving families information that they can review at home. So we hear, not uncommonly in practice that maybe it's a partner, another caregiver who has concerns about vaccines. So providing the family with some information to bring home to that other caregiver, and then actually setting up an appointment to have them come back in to discuss and review that information. We know that keeping vaccines prominent in your clinic is really important. So posting flyers or having them available, handouts and such in the exam rooms or in the waiting areas. There's a lot of time that families are sitting around, and that's an opportunity for them to be engaging with materials around them. Here are some suggested resources, including the AAP and the AAFP and CDC. I also really love the resources that are available on the Children's Hospital of Philadelphia Vaccine Education Center. And then the HPV Roundtable has a lot of great information around HPV at 9. And if you're ever looking for resources, feel free to reach out to our WatchUp team and your coach to help point you in the direction of some resources. And then sort of switching to staff and provider level strategies. We talked about this a moment ago, but really one of the key and most important strategies for increasing uptake is using effective vaccine communication. And much of this work actually has been built upon work that Doug Opal has done here in the Puget Sound area. So we know that providers and other staff members need to be offering a strong presumptive vaccine recommendation for those families who initially resist, making sure that you're continuing to pursue that initial recommendation and explain sort of why it's important for the child to get vaccinated. If the family has specific vaccine concerns, you want to address those concerns and tailor your communication to that patient and family. You could employ techniques like motivational interviewing in those conversations around vaccine concerns. It's really important that there's consistent messaging across the entire care team. And that you're ensuring ongoing conversation. So even those families who decline, you want to make sure that you're continuing to ask about vaccines and talk about vaccines, recommend vaccines at future visits. And I'll just add here in terms of consistent messaging across the care team, I think that this is really key. And one of our clinics in the last cohort, one of their interventions was to focus on MA education, and they, in their practice, the MAs introduced the idea or the vaccination needs to the family at the time of rooming. So they provided some education about how to do that in a presumptive way. Your child's going to be due for this, and this vaccines, and sort of empowering them with scripting to do that. And they saw tremendous success in their clinic in some of those trainings that they did with their MA team. So highly encourage you to think about this in your practice. In addition, using pre-visit prep and huddles, so taking time to review the patient vaccine records and identify those who are due or overdue for vaccines, and then sharing that forecasting within the care team at the daily huddle. So between the MA or the nurse or the provider, and making sure that everybody's on the same page with respect to who and which patients need to be vaccinated in that clinic session. You could implement vaccine prompts and standing orders. So using both electronic health record prompts or even non-EHR prompts. We, talk about the front cover sheet of your paper chart with just a little note of this patient's due for these vaccines as a way to remember to actually screen and order the vaccines during that patient visit. And those can be particularly important when you're thinking about those non-well visits, so your acute care visits and others. Also standing orders, we talked a little bit about this, but the written protocols that allow other healthcare professionals, so your MAs or your nurses, to go ahead and identify patients who need vaccines and administer them. And this helps with sort of streamlining your workflows and your processes in your clinic. And it also empowers members of your team to sort of all be working towards the same goal of vaccinating your patients that you serve. And I'm going to turn it over, Sherry, to talk a little bit more about some of additional strategies.
Sure. Thank you. Hi, everybody. Monica's actually touched on a lot of these through the previous slides, so I'll go through these pretty quickly. But I'm really a believer that if you standardize your vaccination processes, it not only unifies your entire team, but it really can streamline your workflows. And that's that sustainability piece. And we talked about, we want to increase our opportunities to finish the vaccine series on time and increase our coverage rates. So those strategies are, as she mentioned, recommending at the earliest opportunity, like do the kindergarten shots at 4, start HPV at 9 instead of waiting till later, and then offering at all visit types. So thinking about acute care visits and nurse visits and behavioral health. We just want to catch them while they're there. So instead of having to chase them to pull them back for a visit, if they're in your clinic and they're due for a vaccine, give it to them. Or if you can't give it to them, at least recommend it and make a plan for giving it to them. Next. So this is a little bit more about the poster that we've talked about. And, you know, as Annika was talking about the different barriers to vaccination, this actually helps solve some of them, because one of the barriers is that parents aren't aware. So if you post the schedule, it really increases transparency. The parents can see it while they're sitting there waiting, and they like knowing what's next, and actually helps them prepare their kids. Like, you know, Marcus, you need this shot. It's on the poster and the doctor recommends it, and so you must get it. Parents love having the poster as like a firm, it backs them up, right? When they're talking to their kids that this, you must get this vaccine. So anyway, parents love this, and the staff really likes it too, because we know we have a lot of new staff and the vaccine schedule is complicated. So this is like having the cheat sheet on the wall. They can quickly look at it, and it keeps your entire clinic going the same direction, and really decreases confusion and errors from the staff perspective. And the providers say, you know, this adds so much authority. It's like having a second voice in the room. One provider even told me, she goes, now the people know I'm not making this stuff up. Like, the vaccine schedule is here. This is what our clinic, you know, this is our standard schedule. It follows with CDC and DOH. So it's really helpful. When we've surveyed providers, 71% said it was extremely helpful, and the other 29% said it was somewhat helpful. So I'd really recommend a standardized poster. But it's not just one thing to put up the poster. You want to train your staff on how to interact with the poster. And here's some examples that of other clinics that have gone through our program, some of their immunization posters. And you do want to teach your staff to say, hey, you know, this is our vaccine schedule. You can see on the schedule you're due, or next visit you'll be due for this shot. So you want to use the schedule to interact with your parents to improve the vaccination rates. And if your clinic doesn't have a marketing group who can make a poster, on the previous slide, that the one with the colorful boxes, that's a template that we made that's on, yeah, thank you. That's on the AAP website, our Washington Chapter AAP website. So you could use that template and change it, edit it, change the colors, add your logo, change the combination vaccines, everything like that. Next. So a little bit about starting at age 9. It is best practice. The AAP has recommended it as best practice since 2018, and Washington State now forecasts that HPV is due at age 9. That's been since January of last year. It really solves some of those barriers to vaccination. And we know that the HEDIS rates are really driven by low rates of HPV vaccination. And we know if you start at 9, it does increase the on-time HPV completion rate by age 13. It also results in easier conversations. Providers, they find that it's easier to stay on the cancer prevention topic instead of veering into the awkward kind of sex talk. And it's also just gives you 4 years to get those kids the 2 doses. So that can be really helpful if there's access issues or disruptions in care. And probably one of my biggest things right now that I've been realized the benefit of age 9 is it allows for a more relaxed approach to hesitancy. And what I mean by that is, you know, if you're recommending HPV at age 11 to 12 and the patient decides not to get it for one reason or another, maybe they just don't want 3 shots all at once, you've kind of lost that opportunity. And I always felt pressured to try to, you know, like, no, please get it now. But if you start at 9, if they often won't get it at 9, and if they have hesitancy because they need to talk with another parent, they have the time to get that done and really feel comfortable about getting the vaccine. Next. Oh, before we move off, there's a new webpage that went up last week. It's the doh.wa.gov HPV at 9, and it is a fantastic simplified webpage with everything that the DOH has to support your HPV at 9 work. So I'd really highly recommend looking through that. So if you're interested in working on HPV at 9, we've got a lot of resources for you.
Awesome.
Next.
Thanks, Sherry.
Sure.
Great. So just in wrapping up, then at the practice level, there are some strategies that you can employ. So that includes increasing access to vaccines. So thinking about expanded hours or vaccine only visit, vaccine fairs or clinics. And that might be particularly useful at times where you have high volumes, like in getting, later this summer when you're getting ready for those, getting kids caught up and ready for school and school entry. In addition, you could consider audit and feedback reports. So sharing your vaccination rates at the individual level or at the team level or the practice level. And you could sort of initiate some friendly competitions. And so I wanted to share an example of that from one of our participants in a past cohort. So this was South Sound Pediatrics, and they did a couple of really fun, cool games to engage their whole team. And really motivate them to work on reducing their missed opportunities. So you can see some of these pictures are around their vaccine roundup. So the patients were the cowboys or the cowgirls, and they were going to sort of lasso them in as the captured opportunity. And the teams that wrangled in the most or lassoed in the most patients and got them vaccinated moved forward on this whiteboard. So really fun way to engage the teams, also the Cupid bingo shot. So cool sort of innovative ideas to get everybody on board with vaccinating patients. And with that, I'm going to turn it over to Sarah and to Marina.
Thank you, Annika and Sherry. Yeah, so as Sarah had mentioned earlier, we do have funding available from WellPoint, and this is to complete your reminder recall efforts. So something everyone will be doing is reminder recall, and then separately, there is support if you would like, optional to hold a vaccine clinic. So just wanted to speak a little more to what that is going to look like for this cohort. We have incentive gift cards to offer for a reminder recall for everyone. So what you'll do is work with your coach in your coach calls, and we want you to set a goal for the number of patients you want to outreach to. This is something that you'll document in a monthly survey that will already go out just to say how many patients you did contact. So set a goal for June 30th, kind of the first half of that intervention period, and then the second half of the intervention period of who you want to outreach to by August 31st.
And Marina, let me just make a clarifying point that the gift card or cards are for the staff who are actually doing the outreach. So it's not for everyone. It's for all your clinics. We'd like you all to set a goal, and we would like to provide a gift card for the staff who are responsible to do this outreach, because their regular jobs still exist, and they're going to need to start to build this into their workflow and their pattern, and it will take some time. So we will make sure that they get recognized for that extra time.
Right. Thank you. Yeah, we recognize it definitely takes time. So wanting to celebrate that. And then there's also a team celebration available. So you can hold that in July or September if you want to do midway or at the end. And that would be—
You can do both, actually, depending. I think it's probably possible to do both if you want. We'll have up to $500 for food for you. And so it depends how big your clinic is, if you want to do one or two, or what works for you. But it is, Annika showed the slides about the roundup and the celebration. And that's the idea, is to generate some enthusiasm and appreciation for people. So this could be, something that works within your globe. It could be breakfast, it could be pizza, whenever, whatever. But there is some funding available to provide that opportunity as a community to focus on this and celebrate the work.
Yes, and then other than that, there's the vaccine clinic. And so we do have funding for that. If you're interested, we ask that you let us know by the end of May. It's something you can think about with your team. It's not required, but we do have funding available to help support evening, weekend vaccine clinic. You could think about providing patient giveaways, something to incentivize patients to come in. Anything else to add to that, Sarah, before we move on?
Well, just the thanks to WellPoint and the amount of the incentive for your staff will depend how many staff you have doing that work. And the amount for the vaccine clinic, standing up a vaccine clinic, will depend how many of you want to do that. We expect we could provide in the neighborhood of $1,000 to $1,500 for you to do that, but it also depends how many clinics want to do it. So that's part of why we want to get this going. We want you to help reach the kids before school starts, right? So plan your event, get it on the books. But we also need to know how many of you want to do it so that we can help you understand how much funding is available to you. Thanks. Oh, and just again, that WellPoint made this possible. We've wanted to provide at least some financial support for clinics since we started this initiative in 2019. And this is the first time we've been able to. So we're really excited to give you a little bit of it.
Great. And you all got to meet Crystal today. So looking at next steps, that's kind of what's going on now. If you haven't had a chance to meet with her yet and you would like to still, just please send me an email and we can get you on the schedule for a WAYS meeting. Otherwise, looking forward to receiving your process maps. So just go ahead and email those to me. It looks like we have a couple minutes left. I would like to ask just if anyone has a question really quickly on your process maps.
Do you know what that is? Right out there.
Anything else?
Either a good sign or a bad sign. We'll find out soon. Oh, and I know a few coach calls are happening before this April 5th deadline. If you're able to get your process map in before your coach call, that'd be helpful to have your coach will be able to review it with you at that time. And then just wanted to differentiate between the coach call and the MOC call, and they can kind of be confusing. So the coach call is really to review all the data that you worked hard to submit. So our data manager, Michelle, created some beautiful slides showing your data over your baseline period, and you'll have time to review with your coach all of that and start thinking about what you want your intervention to be. The MOC meeting is a little separate. That's where you're leading your team, showing them, this is the project, this is kind of what we're thinking for interventions, get some input from your team and kind of get some buy-in and get them excited to start the intervention on May 1st. And then here's some MOC and CME were able to get credits. So again, there's a list here of who it's available to, but I won't read the whole list, I'll let you read that. But what it is those 3 MOC meetings that they need to attend. So if you want the credit, this upcoming MOC meeting in April needs to be attended. And then there's another one, I believe, in July and September. And we'll send over a link shortly that you can sign up. It's a little survey just to say, like, this is my name, this is my email, I want these credits, and I intend to participate at those 3 meetings. And this is just the coaching assignments that you'll be meeting with your coaches in April. I think that is all for me. Oh, this is again just a reminder of our resources webpage. So there's a link here. I also send it out in the emails I send you guys. You can click there. And this is where the videos will be posted as well. And that's all for me. Anyone else want to add anything or have any questions?
No, just thank you for everything.
Thanks, Christian. So if you think of any questions or, feel free to reach out to any of us. Otherwise, we will see you at your coach check-in meetings. As Marina said, to review your baseline data and start